Hi, so quickly let's talk about upper GI bleeding. So bleeding from the GIT above the ligament of Treitz is basically upper GI bleeding, and the etiology is based on esophageal varices, gastritis, and gastric ulcers, duodenal ulcers, AV malformation, malignancies in the stomach and the esophagus, Mallory's syndrome, and polyps can also be an etiology of GIT bleeding. So clinical features include vomiting of fresh blood, which is bright, or coffee ground vomitus, that is hematemesis. That's forcefully vomiting followed by hematemesis suggests gastroesophageal junction tear, and excessive alcohol intake or ingestion of anti-inflammatory drugs may suggest erosive gastritis, and previous epigastric pain suggests peptic ulcers in massive hemorrhage, and blood may appear per rectum. So investigations include one supposed to do an hemoglobin level to also check a platelet count. Investigations based on the cause can be liver function tests, barium swallow meals after the patient is stable, and an endoscopy if available, so as to check out the clinical features and the structure of the anatomy in the stomach. How do we manage this? We manage this by giving a large IV line and start an infusion of normal saline. Group and cross match at least 3 units of blood so as to cover for the loss. Perform gastric sanctioning to assess blood loss, and also infuse fluids to maintain normal pulse, blood pressure, and urine output, and also substitute whole blood as soon as possible so as not the patient cannot be able to go into a shock. Also assess any further loss of blood as evidenced by a persistent tachycardia, postural hypotension, and continuing of hematemesis. And you're supposed to seek hospitalization if the condition worsens, and if there's active light bright red blood that is presenting as a vomitus. Thank you. I hope you've learned something.